So, good afternoon, my dear friends. It's my great pleasure and privilege to open this Heart Cafe. It's another Heart Cafe, which is an initiative of the World Heart Federation. The idea of the Heart Cafe is to have some colleagues, some experts discussing some topics which we feel are relevant for discussing cardiovascular health. And today we're going to discuss one of our roadmaps, which will be on fixed dose combination, which, as we know, is one of the areas where many of us have been working, promoting, because we believe that, but that's of course part of the discussion, but we believe that fixed dose combination can actually improve. One of the main aspects that we're still having a problem in clinical medicine, which is adherence to treatment. Adherence to treatment is one of the big issues that we face globally. It's not a problem of a country or a region. And we're trying to find strategies that can help us to overcome these limitations. And one of them is fixed dose combination. And that was the reason why at WHF we decided to develop this roadmap. The roadmap is an initiative of the World Heart Federation where we try to identify barriers and provide suggestions and potential strategies or help to promote strategies that can address topics, issues, difficulties. And in this case, we're going to focus on fixed dose combination therapy and how that can improve cardiovascular disease management, actually to promote cardiovascular health and in disease, of course. It is my great pleasure to have with me four outstanding speakers, and they will be also addressing some of the questions that we're going to raise during this conversation. And of course, it's also open for discussion. We have 1 hour. So it's also open for discussion of any of you that would like to ask any question or make any comment. I have with me Professor Habib Gamra. Habib is a good friend from long time ago. He's an interventional cardiologist in Tunisia, and he's been also involved in this roadmap very much, and in this area. And he will be addressing some of the issues related with fixed dose combination. Then we have Dr. Adriana Murphy from the London School of Hygiene and Tropical Medicine, so she's from the local team. Then Dr. Gautam Satish is a cardiovascular researcher. He's based in India, in Bangalore. He belongs to the George Institute. And then, last but not the least, Mrs. Maria George. She's from a patient organization, and she actually been very instrumental in many activities. And I have really to congratulate you for the job that you are doing as a patient organization. Is the INOCA International that has been discussing many issues related, particularly with ischemic heart disease, and particularly with this topic of INOCA. Now we have an ANOCA also. It's angina with non-obstructive coronary artery. So these are the panelists that will be discussing some of the topics that we will be addressing. Okay, so after this introduction, I also would like to thank our sponsor. Our sponsor is Servier, and we really want to thank the support for the Heart Cafe initiative. It's very important, this type of partnership, because it allows to develop this type of events that we hope can be useful for all of us. So let's start. And I will start with my good friend Habib. And maybe the first question is if you give us a little bit more detail about these fixed dose combinations that currently are available for treating different risk factors and also in patients with already established cardiovascular disease. What is the evidence and what recommendations are supporting the use of fixed dose combination? Habib.
Okay, thank you very much. First of all, I'm really honored to be part of this initiative launched by WHF and supported by Servier. Honored and pleased because I think it's a very important strategy to promote adherence of the patients to medication, improve outcomes, and also to save money because it could be cost saving also for the health system. So FDCs or polypills that was introduced more than 20 years ago has been progressing slowly in terms of widespread implementation. It has started by evidence in primary prevention, and I was honored by being part of one of the big trials, the TIPSI trial, that was initiated by Salim Youssef in a multinational study that has involved more than 5,000 patients for primary prevention again. using an FDC combination of diuretic, beta blocker, statin, and ACE inhibitor, and it has shown very clearly a significant reduction in cardiovascular events by 25 to 30%. So it's a very significant. And after TIPS trial, there was a meta-analysis that we published in Lancet just 1 year after, that was in 2021, including another trial that was conducted in Iran, the Iran trial, and HOPE-2 trial, and it has shown the same thing, a significant benefit in terms of cardiovascular events reduction. Now, this is primary prevention. For secondary prevention, there was a trial that was published in 2022. It's called the SECURE trial. It was a European Union funded trial, and it has enrolled patients post-AMAD with an FDC that has included aspirin, ACE inhibitor, and beta blocker. And again, we have positive result in that trial. So evidence is there. And by the way, even the USC guidelines in 2023 for ACS, they do recommend the FDC for secondary prevention. So evidence is there.
I was actually going to ask you specifically about acute coronary syndromes. If you could give us a little bit more information and what evidence we have to support also in ACS in acute coronary syndrome. So not only in chronic, but also in acute.
Yeah. Now for chronic and post-AMAD, that's the SECURE. Now for acute coronary syndrome, unfortunately, we don't have much trials so far. And I think it's about time now, perhaps, to conduct trials in that, because we go from the least unstable situation to the more unstable situation. So I think we need more evidence now for acute coronary syndrome for that particular strategy.
Absolutely. Maybe we move now to Adriana, and based on your research that you've been doing in different parts of the world, and particularly I was alluding now to Kenya, what are, in your perspective, the key health system factors that may actually influence the successful implementation of fixed dose combinations to manage, for instance, hypertension, and in that regard, to improve, because that's really been a big problem to manage hypertensive patients. But I know you have some experience. So can you share that with us, please?
Yeah, sure. Thanks. And I'm glad for this question, because this is one of the main focus areas of our roadmap, is to try to identify all the health system barriers to implementation of fixed dose combinations. And what we found is it's actually very complex. And there are many interdependent barriers that are not simple to address. And so I don't want to suggest in my summary answer that it's a simple problem and that there are very few barriers, but I will focus on just a few. And these are the ones that we want to focus on the roadmap, because they're very specific, I think, to fixed dose combinations. And this comes from work in Kenya, but also other low income settings. So one of the issues is that with the polypill specifically, there are very few manufacturers of the polypill. So manufacturing of the polypill is limited, largely because there are very few incentives for a lot of manufacturers. Most of the drugs are off patent, so the profit margins are low. And with regulatory hurdles and so on, there are a lot of disincentives, and in many cases, demand is very low. So this is one of the issues we looked, and this is not a comprehensive count, but what we found was roughly 11 or 12 manufacturers globally of the polypill. And just to give you an idea, some of the components will have many times that in terms of manufacturers. And so another issue is that in international guidelines and in national guidelines, fixed dose combinations are still not prioritized in most cases. So we know, of course, that the polypill's been added to the WHO EML, and earlier in 2019, combinations for hypertension were added. But national EMLs are much slower to pick that up. And also international guidelines don't all across the board explicitly prioritize fixed dose combinations. And so that's an issue when it comes to prioritizing them in the public sector in most countries. Thirdly, this links, of course, to the other barriers. And like I said, they're all interconnected. There's very low availability of affordable fixed dose combinations in the public sector in most countries. We did a survey with the WHF where we found in all of the public sector pharmacies that were surveyed, absolutely no poly pills available. And of course, this links with the National Essential Medicine List and so on, but it's clearly a problem because doctors won't prescribe things that aren't available in facilities. And that brings me to the last barrier that we're going to focus on in the roadmap, and that is uptake among clinicians and prescribers. And among many clinicians, there are known sort of concerns around dose titration and so on. But what we don't often think about is that, in fact, in our work in Kenya, we found that most clinicians are very happy about the concept of combinations. They think it will lower patient burden, improve adherence, but they simply don't want to prescribe things that aren't readily available at an affordable price. And so, of course, like I said, all of these are interconnected, but those are some of the main barriers that we really want to tackle in the roadmap.
Do you want to elaborate a little bit more on the economic barriers? You've done a study, actually you mentioned that, in other parts of Africa, in Tanzania, in Zimbabwe, and so on. How much these economic barriers, if you want to elaborate a little bit more, can actually affect the uptake of FDC in these countries? Yeah.
A lot. So in general, and I think the work that you're referring to, we did in South Africa, Zimbabwe, Tanzania. Some of this was nested also in the PURE study. You mentioned Dr. Salim Yusuf. Some of it was separate. But in many other countries also, researchers have found that people with cardiovascular disease and with hypertension are often incurring catastrophic health expenditures. And overall, the largest driver of that is the cost of medicines. Because in the public sector, often consultations are covered, but medicines aren't always covered. And if they are covered, they're often unavailable. And so I think actually that fixed dose combinations can be something that improves or reduces, let's say, economic barriers, because often the costs that are incurred are not just the cost of the medication, but the cost of going to facilities, finding facilities that have different medications in stock. And there is some idea that a fixed dose combination can reduce the burden on supply chains and be more readily available in the public sector. And it would also reduce what some people do to cope with the economic costs of medications, and that is to take one, let's say, molecule for a certain period of time, and when that runs out, get another, and so they're not taking them all at the same time as they should be.
Yeah. Well, let's move now, just following these comments to you, Gautam. With your experience at the Georgia Institute for Global Health, in your perspective, what could be the most effective strategies that could scale up the use of FDCs, particularly in resource-limited health systems?
Most of the research that I do at the Georgia Institute particularly focuses on translating this evidence into both policy and practice. And of course, fixed dose combinations are a major focus now that most guidelines, at least for hypertension, they do recommend fixed dose combinations. So, a lot of the literature cites manufacturing, capacity as one of the major barriers. But let's take the case of India, which is, sometimes I would you could say it's a resource limited settings. Most of it is. And India, we don't have a shortage of any generic manufacturers, and consequently, even the prices are not that high either. Yet, when we did that survey that Adriana just spoke about, the multi-country survey in India, what we learned is that there are so many brands available in the market, yet they're not adequately stocked even in the big hospitals or in the major cities. So the only way we can ensure that fixed dose combinations are adequately stocked, including in resource limited systems, is to include it in the National Essential Medicines List, because that then opens the doors for its inclusion in state lists and hospital formularies, etc., just thus ensuring coverage. But that's only one part of the problem. The other part is on the demand side. So the awareness among prescribers for, when it comes to FDCs is still low. Even if the guidelines are recommending it, the adoption at the clinical practice level still remains very slow in most low and middle income countries. And I think this is where, I can cite an example that has historically worked for hypertension when it comes to fixed dose combinations, which is standard treatment protocols. Now, standard treatment protocols are very different from the regular clinical practice guidelines, which are more comprehensive. They provide recommendations on all available treatment based on certainty of evidence. Standard treatment protocols are very simple. They focus on 2 or 3 medicines and in less than 5 simple steps. So they're so simplified that most healthcare providers, including non-physician providers, can administer them to manage most of the patients. WHO in 2021 hypertension guidelines prioritizes simple protocolized care for hypertension. And naturally, like, although if you take any of the major global hypertension control efforts, say the HEARTS package, which is implemented in over 40, I think 40, over 40 countries and resolved to save lives, their hypertension efforts are implemented in at least 32 low and middle income countries. The standard treatment protocols form the core of these programs, and they're administered to the majority of the population in these areas. And more of these treatment protocols now use fixed dose combinations. So I can't think of a better way to upscale this fixed dose combination than incorporating it into programs that are already in place. In India, we have something called the India Hypertension Control Initiative, which is implemented in majority of the states, but they still do it with monotherapy. But we at the George, we are actually doing a trial now, which is a sort of an extension of what the India Hypertension Control Initiative is doing, but with fixed dose combinations. And recently, I don't know if you've attended Anthony's talk. So in Nigeria, we did something similar, where we used protocols with fixed dose combinations, and we had tremendous results. And I think these findings can definitely inform the evidence and also generate awareness. Now, I know I spoke mostly about hypertension, but even for primary and secondary prevention of cardiovascular disease, I think polypills will also be incorporated, at least for those at high risk of cardiovascular diseases. So yeah, incorporating into existing programs.
Of course, one of the issues that you already spoke a little bit is about equity and about how we can improve and how we can develop measures that can particularly ensure that the underserved populations have access to these fixed dose combinations. And can you share with us, what sort of strategies can improve this, if you will, to reduce inequity in access to medication, and therefore to be able to reach out more to the underserved populations?
Yeah, I mean, the strategies I mentioned right now definitely addresses the inequities, especially the geographical and financial inequities. Inclusion in the essential medicines list can bring them under price control, and also include these medicines in the public sector, which in most low and middle income countries is the only source where patient can get medicines free of cost or at subsidized cost. So that covers the financial inequities and geographical, as I said. These the incorporation to programs will ensure that these are administered to masses. And another thing that we are exploring at the George Institute for geographical accessibility, and as well as the last mile delivery of medicines, is digital health through online pharmacies. So after COVID-19, online pharmacies and the use of telemedicine in general has increased dramatically, especially in low and middle income countries. Now, there's not a very fixed dose combination specific solution, but it does, given the prioritization and penetration of digital health globally, I think it's an effective strategy. Now, as far as traditional pharmacies are concerned, it's difficult to propose a single strategy to improve accessibility to FDCs, given their complex supply chains, which are largely driven by demand and prescribing patterns. And this is something that we try to explain in the roadmap too. There is this complex interplay of several interconnected factors, and it's never linear, and it involves multiple parties. There's manufacturers, prescribers, distributors, physicians, policymakers, etc. And I think to address any inequity, I think the best place to start is to identify determinants and assess the gaps. And I think roadmaps are a great place to start that. And in 2022, the American Heart Association had issued a roadmap on how to leverage implementation science to address cardiovascular health inequities. And they too mentioned two major things. One is that there is a lack of understanding and lack of research. Two, there is a lack of understanding on how multi-level interventions work to address inequities. In our roadmap, we do identify the major barriers to equitable access, and we also propose actionable solutions on how we could possibly address them. So I think this is a great place to start.
Very good. Maria, you are here, the voice of the patient. Actually, we are all potential patients, so that's something that we all share. But it's very important from a patient perspective to understand what is your perception, and if you want to share with us now as a patient representative, how do patients see the use of fixed dose combination when compared with the more traditional, multi-drug use for treating hypertension, diabetes, whatever?
First of all, thank you for including the voice of a patient, as always. First and foremost, I think the general consensus is that it's welcomed on the basis that it addresses a much easier, a much simplified way of taking medication. And many heart patients take lots of medications. So if there's a way to simplify that and to make it easier to take, even better. I think there are some concerns, and that's understandable, around side effects, around what goes with which and how that's going to be effectively put out there. And I think that's understandable. But I think also part of reassurance is education. We need to discover what it means and what the policies and processes are around fixed dose combinations. And we need to discuss that with patients and make them aware, because if you reassure, if you educate, if you support, you take away fear. Fear is just the unknown for patients. And I think a lot of it is, if we can learn more about it and about its implementation, I think it'd be welcomed. And the last point I'd like to make on that is a lot of adherence, you mentioned adherence, a lot of non-adherence relates around non-intentional non-adherence. So in effect, fixed dose combinations, I think, would help very much in that, because in that non-intentional one, there's a lack of capacity often, or a lack of resources, whether it's cost or availability, as you mentioned. And I think fixed dose combination would help in that too.
Yeah, absolutely. And how do you think patient groups such as yours can actually, and you mentioned education, support to patients, how can you actually help and contribute to improve education, to improve this kind of support, to work with societies or organizations such as ESC, WHF, and so on? So how can the patient groups really make a difference here?
I think that's a huge key. And I think we have to do that. It's as simple as that. I mean, we work already with World Heart Federation, with ESC, with all the big organizations. And it's important that we learn ourselves. We have a phrase in Oak International of listen, learn, and then lead on it. And I think that's what we have to do. We have to find out for ourselves and then discuss it. Open forums, online forums. Lots of patients go online. So make use of that. Give them information online, but reliable, responsible information, so that they can learn for themselves. I think we have a key role to play in that.
Absolutely. Now, if anybody would like to ask a question, please feel free to do that. Meanwhile, we'll continue with our conversation. Habib, one of the barriers has to do with us, the doctors, the cardiologists, or practitioners. What can we do to improve, on one hand, the awareness, the understanding, and basically to improve the way our colleagues can actually have a better way to use fixed dose combinations, as we think that that's important for patient management. So what kind of things do you think we can help as physicians, now focusing specifically in our role as doctors?
I would say simply education, of course. It's a general word, but it's not enough. Now, having guidelines mentioning the importance of using FDC as a strong strategy to improve outcomes, this is an important thing. Now, of course, all our colleagues, they don't follow guidelines. So I think having trials, convincing trials, particularly in acute coronary syndrome setting, having that in those guys and repeating occasions to educate our colleagues is the best, is the way to go. So it will take some time. Now, I just wanted to mention something that is crucial. I mean, I've been discussing with Adriana and Gautam and all the colleagues for the roadmap, the challenges. But I think one of them, and maybe one important one, is the cost. All health systems around the world, in rich and poor countries, now they are impacted by the cost of health care. So if the FDC becomes more interesting than the usual way of treating patients, then it will be attractive, because reimbursement will be easier, and this will push colleagues, of course, to go that way. By the way, one of the ways that was effective in other countries is to base reimbursement on the use of FDCs. So if you use FDC, you're reimbursed. If you don't use it, you are not reimbursed. And this is one of the ways that can be really effective in widespread implementation of FDC strategy.
One of the things that you actually mentioned is the inclusion of FDCs in EMLs. How do you think that can actually, on one hand, how important that is, if you want to elaborate a little bit, and also what can we do to increase that list and to increase the inclusion of FDCs in EMLs?
Yeah. So with your first question, it's important because in most countries where there is a national essential medicine list, that list dictates what is procured for public sector facilities, and the public sector procurement agencies cannot procure something that is not on the essential medicine list in many cases. So that's why it's important. How we can encourage more countries to include it? Well, the WHO including it is a big step. International clinical guidelines including it is a big step. But I think because there's that responsibility to procure it if it's on the essential medicine list, governments want to know that they can afford it and that they can make sure it's available. And I think what I always think of what researchers can do, because I'm a researcher, I think we could be doing more work in specific country settings to show the cost effectiveness of FDCs compared to individual molecules. Because the answer we often get from government stakeholders is, oh, it's too expensive. But I think, as Habib said, if there were an attractive or affordable price point and it could be compared with the individual molecules over time to see, sort of longer term health gains, but also gains to the health system, I think that would be really important research in order to advocate for inclusion on essential medicine lists.
Excellent. Gautam, do you want to share with us, just following what Adriana mentioned, in your institute, which has been doing a lot of work, and particularly in some settings, you want to share with us some of the programs? You already mentioned a couple, but do you want to expand a little bit on some of the programs that you are developing to improve FTC implementation, how we can, in certain areas, use strategies that can help us to penetrate this type of FTCs? What is your institute doing? And tell us a little bit more about the work that you've been doing.
Yeah, so we are doing a trial called the New Step, which again deals with the standard treatment protocols. And our idea is to start with initial combinations for hypertension and then move to the triple combinations. So that's something that we are currently in the process of implementing. So we are in the formative phase right now, and I think we are planning to do it in around 5 states. So we get a large sample with different centers, and that's a very important, next step to what the India Hypertension Control Initiative, which is the larger program, is already doing in India. But they do it with monotherapy and we do it with fixed dose combinations. So we are kind of showing that, we are kind of developing the evidence that it is possible, it is economically feasible, because we do plan on a feasibility trial at the end of it. So we are planning to generate the much needed evidence to tackle the problems that Adriana said is usually, brought to us when we talk about FDCs. So that's one thing. And we have done, as I mentioned earlier, we have done this similar trial in Nigeria called the Veronica, which recently got published. And we did generate evidence on, using triple combinations, low dose triple combinations for, hypertension. So we are doing mostly around hypertension right now and not on cardiovascular diseases yet. But hopefully, the next step would be to look at follicles too.
Very good. Maria, talking about evidence guidelines. The position of patient organization in guidelines is increasing. Now it's being part of many of the guidelines. So what would you, if you would sit on the guidelines committee or task force, what would you recommend? What would you say to the task force about fixed dose combination as a strategy, as a way to improve patient adherence and so on? But now from a patient's perspective, what would you recommend to I'm the task force chair, you are sitting in the task force on hypertension. What would you say, as a patient representative?
As an individual patient, I would say, I think it has huge scope. That's the first thing. I think it's important to take care how it's presented. I think it's important to reassure in evidence, as you quite rightly say. And I think the evidence has to be partly patient-based. You have to have patients feeding in to how they're perceiving it themselves and actually what they're looking at and looking for from a fixed dose combination. When I heard I was going to be part of this forum today, I actually asked the question in an online forum of angina patients of 4,000 patients and said, how do you feel about fixed dose combination? And really the only concern was what happens if there's a side effect of one of those drugs. So some of it is just digging a little deeper. so that there's sufficient knowledge available, but the knowledge that has to come has to be understandable. So it has to be really what they call plain English. I call it easy speak. Put visuals in it, make it very simple, very straightforward, so that not only do the doctors understand exactly what the chemical and medical side of it is, patients understand how that will affect them on the ground. Because impacts of multimorbidity is huge. And it's not just about your actual lifestyle. It's about you can lose who you are, you can lose a sense of yourself. You know, depression. There was a recent study of 7,000 patients, and patients with one condition, 23% reported depression. Patients with 5 conditions or more, multimorbidity, 40%. So multimorbidity is one of the key things that I think fixed dose combination will be absolutely wonderful for, but we have to let patients understand it. So we have to be clear.
Absolutely. So, Habib, we've been talking mostly on hypertension, a little bit on ischemic heart disease. You know, where do you see in different clinical conditions the role of FDCs? You know, on not only on hypertension, on ischemic heart disease. Are there any other potential indications where it can help?
One potential and I think definite indication is heart failure. You know that heart failure now rely on, I would say, 4 important drugs. They must be in one pill. And if that can achieve, this will improve a lot. First of all, adherence, because it's patients with heart failure, they take many medications along the day, and you are not sure if you are a patient one day, you realize how difficult it is to take 4 or 5 medications a day, different times of the day. So if you can have 1 or 2 pills to take, I think this will improve substantially adherence and outcomes. Cardiovascular disease, I think heart failure would be one important potential indication.
Very good. Adriana, we've been focusing a little bit on low-income settings, but the problem of fixed dose combinations also happens even in high-income settings. But of course, the barriers may be different. Do you want to comment now, in your perspective, in the high-income countries, what are the main barriers or the main issues facing, let's say, the lack of adherence to fixed dose combinations that we are still seeing?
Lack of adherence or lack of uptake, maybe.
Or uptake, yeah.
I think in high income settings more than in low income settings, I want to blame the cardiologists.
Good.
Okay.
We take the blame.
But I don't know. From my perspective, I think combinations are often seen as a poor patient's solution or a poor country solution, and maybe less customizable, less sort of boutique medication. And there's a perception that in higher income countries, I think that a patient deserves kind of a more personalized approach. And I think that's possibly one barrier in high income countries that we see, but it's not.
Yeah, no, I
not
agree.
all your fault.
Maria, do you agree that patients may see this as a kind of a second-class treatment?
I think they might, but I think that's about us again. That's up to us to make it clear. You know, I mean, you can have people who are desperate for a fixed dose combination. It doesn't mean it's a lesser treatment. It could work much better and much more impactfully for that person. I think there's definitely an element of that, but I think that's on us. The responsibility of that is on us to make it clear that that's not the case.
Absolutely. Well, I think this has really been an exciting discussion. I will give now the opportunity for each one of you just to have sort of a final statement regarding this topic, not only about the roadmap, but the whole topic of fixed dose combinations. In your perspective, what will be your message? What will be your, let's say, your view to finalize this our discussion? And I'll start with you, Gautam.
Yeah, I think, I mean, we have heard successful stories of fixed dose combinations from, the infectious diseases. And I believe I'm optimistic that this is going to happen for cardiovascular disease as well. It is getting more and more implemented. We had last year, we got the polypills in the essential medicines list last year in WHF essential medicines list. Now we are actually preparing for another application for the triple dose antihypertensives in the next edition of the WHO EML. So, and with the guidelines now, starting to recommend not just for hypertension, but for cardiovascular disease as well, I do see an optimistic future. And I think this roadmap definitely clears the air on many of the concerns regarding the fixed dose combinations.
Very good. Habib,
I would
final messages,
yeah,
bullet points.
I would insist on the close partnership between doctors and industry partners, because this goes through industry partners necessarily. If you don't have the drugs available at the dosing that the prescriber wish, and then help them how to promote those drugs, and reassure them that there's business even in FDC. And then, of course, collaborate with them to conduct more trials in different settings: acute coronary syndrome, acute heart failure, chronic heart failure. If we don't do that, I'm afraid we'll be taking more time in widespreading the implementation of this strategy.
Very good. Adriana.
I think I'll pick up on the point that Habib mentioned earlier about training and raising awareness among fellow cardiologists in your case. I actually would go a step further and wanted to highlight, in addition to all the health system barriers, the importance of raising awareness among not just cardiologists, but everybody who interacts with a patient and supports adherence to medication. And I'll just, if I may, briefly give an example of a trial or a feasibility study we're planning in Kenya to try to improve implementation of fixed dose combinations for hypertension. And we're working with the Kenyan Cardiac Society for the training, but the target for the training will not just be cardiologists who will be offering it, but the clinical officers in the primary care facilities who prescribe medication and follow up patients, the nurses in those facilities, the community health workers, and importantly, the pharmacists in the community to whom many patients go for refills and advice often. And that, I think, applies in not just low-income settings, in many settings around the world, where there are multiple points at the health system where patients interact and who could be supporting and promoting fixed dose combinations.
That's actually a very interesting aspect you're bringing in, which has a little bit to do with the task shifting and how that can actually improve patient management in different conditions. And hypertension certainly is one of them. And the work you're doing is really fantastic. And we have good experiences also in some countries where starting to develop this type of strategies that can help to improve patient management. Maria, the final word for the patient, what do you want to share with us?
Thank you. I believe that there is huge scope, and I believe fixed dose combination has great potential. I think we have to frame it right. I think we have to make sure that patients have a choice. I think we have to encourage shared decision making so that patients are involved in that choice, because they will engage more in treatment if they're involved in it, in the decisioning, and they'll also take medication much more readily if they are part of the choice of making that. So I think a choice, shared decision making, and we have to frame it right so they understand the drug and keep aware of side effects, so that it's presented, suggested, perhaps even promoted, but not pushed.
Absolutely. So I think we had the opportunity here to discuss several aspects related with fixed dose combination. We addressed some of the issues, some of the questions, some of the limitations, the barriers, but also the expectations that we all have to improve patient management through fixed dose combination. You heard different perspectives here, different comments. I hope this has helped to improve the discussion and hopefully to be able to reach out with better results that we all look for. Also, a word on the WHF roadmaps. We really believe this is an important tool that can be used and should be used. We want this to be useful, should be used by our members, our communities. And again, this has to be adapted. That's another thing that was mentioned. We need to adapt to the local realities, and we don't have one size fits all. We have good solutions, but these need to be discussed and adapted to the different locations, different regions, different settings, different issues that have to be discussed with the local colleagues or with the local members to make sure that the right decisions or the right strategies are being implemented in the right way. So with this, I want to thank my co-panelists. It was really fantastic to have you all here. Of course, thank the World Heart Federation for putting together this Heart Cafe and these sessions. And thank you to Servier for sponsoring and partnering with WHF to make sure that the Heart Cafe is another success. So thank you, and continue to have a great Congress. Thanks a lot.